stool that won't move, no matter how much you strain, how much water you drink, or how much fiber you add to your plate. It's uncomfortable, it's scary, and it keeps happening. But here's the thing. The reason it's happening probably isn't what you've been told. There's a mechanism behind this that rarely gets explained, and once you understand it, everything starts to make sense. Let's start with what's actually going on inside the body when stool becomes stuck. The rectum is the final stretch of the digestive tract, a stretchy muscular chamber that acts like a holding area. When stool arrives, the rectal walls stretch and send a signal to the brain. It's time to go. Normally, this triggers a coordinated sequence. The muscles of the pelvic floor, especially one called the puborectalis, are supposed to relax. The anal sphincter loosens. And with a little help from abdominal pressure, stool moves out. Fecal impaction is different from just feeling backed up for a day or two. It's a large, hardened mass of stool that becomes lodged in the rectum and physically will not pass, even with straining. It can sit there for days. Sometimes liquid stool leaks around it, which confuses people into thinking they have diarrhea when they're actually severely blocked. This isn't simple, everyday constipation. It's a mechanical traffic jam. And understanding why that traffic jam forms is the whole point of this video. So why does it happen? If you've ever looked this up or asked a doctor, you've probably heard the same short list of culprits over and over. Not enough fiber in the diet, so stool doesn't have the bulk it needs to move efficiently. Not enough water, so the colon pulls moisture out of the stool and it hardens. Not enough movement during the day, since a sedentary lifestyle slows down the natural muscle contractions of the intestines. Getting older because muscle tone and nerve sensitivity in the digestive tract can decline with age. And certain medications, especially opioid pain relievers and iron supplements, which are well known for slowing the gut down and drying out stool. All of these are real. They're not myths, and they do contribute to constipation for millions of people. If you're dehydrated and inactive and eating almost no fiber, your risk absolutely goes up. That part of the story is true and no one is disputing it. But here's the problem. Plenty of people do everything right. They drink enough water, they eat vegetables and whole grains, they walk every day, and they still end up with stool stuck in the rectum, sometimes over and over again for months or even years. If diet and hydration were the whole explanation, fixing those things should solve the problem completely. For a huge number of people, it doesn't. They increase fiber and actually feel worse. They drink more water and nothing changes. This is the exact gap where most explanations quietly stop talking. And it's exactly where the real explanation needs to begin. So what's actually happening in these cases? The answer lies not in the food you eat, but in how your muscles and nerves coordinate with each other. This condition is often called pelvic floor dyssynergia, and it's one of the most overlooked reasons stool gets stuck in the rectum. Remember that sequence from earlier. The pelvic floor muscles are supposed to relax when it's time for a bowel movement. In people with dyssynergia, that signal gets crossed. Instead of relaxing, the puborectalis muscle and the anal sphincter actually tighten or contract at the exact moment they should be letting go. Picture trying to push something through a door while another part of your body is simultaneously holding that door shut. You can strain as hard as you want, increase abdominal pressure, do everything textbook advice tells you to do, and it won't matter because the muscles required to open the passage are working against you instead of with you. This isn't something people do on purpose, and it isn't something they're usually aware of. It's a learned subconscious muscle pattern, and it often develops over years, sometimes starting in childhood. A common origin story looks like this. Someone experiences pain during a bowel movement at some point, maybe from a small tear, hemorrhoid, or an especially hard stool. The brain then starts associating the act of bearing down with pain. To protect the body, it begins unconsciously clenching the pelvic floor at the moment of evacuation to prevent that pain from happening again. Over time, this clenching becomes automatic. The muscles simply forget how to relax on command, even after the original injury has healed. The protective reflex outlives the reason it was created. There's a second piece to this puzzle, and it works alongside pelvic floor dyssynergia to make things worse. It's called rectal hyposensitivity, and it has to do with how well the rectum can sense that it's full. Normally, when stool arrives and stretches the rectal wall, nerve endings send a clear signal to the brain that says it's time to go. But in people who routinely ignore or suppress that urge, because they're at work, traveling, avoiding public restrooms, or simply busy, The rectum starts adapting to being stretched more and more before it registers the sensation. Essentially, the nerves become less responsive over time, requiring a larger and larger volume of stool before the urge is even noticed. When you combine these two mechanisms, you get a two-part trap. First, the rectum stops sending strong, timely signals that stool needs to come out, so more and more accumulates and hardens. Second, when a bowel movement is finally attempted, the pelvic floor muscles that are supposed to open the passage instead clamp down, blocking the exit. Stool becomes larger, harder, and stuck behind muscles that won't cooperate. No amount of fiber or water fixes a coordination problem because the muscles were never the ones lacking bulk or moisture in the first place. They were simply never told to relax. And if that line hits home, there's something I want you to see before we keep going. Because there's another overlooked gut trigger that may explain why fiber, water, probiotics, and even healthy routines can still leave people feeling blocked, bloated, and frustrated. A short video breaks down a strange underwater gut superfood used in parts of the world where regularity rates look completely different, and it shows why researchers became interested in one compound inside it that may help support smoother digestion and a calmer gut lining. It's not about forcing your body with harsh laxatives. It's about understanding the missing link most people never hear about. Point your phone camera at the QR code on the screen right now to watch it, or use the link pinned in the comments. Then come right back here, because what we're covering next will make even more sense. This explains why so many people who eat well and stay hydrated still end up dealing with impaction. Diet influences the size and consistency of stool. It does nothing to retrain a nervous system that has stopped signaling properly, or a muscle pattern that has learned to clench instead of release. That's the disconnect that rarely gets addressed. And it's the real reason behind a huge portion of chronic impaction cases that don't respond to standard advice. Certain groups tend to be affected by this mechanism more than others. People with a history of chronic straining or long-term laxative use often develop altered muscle patterns over time. Individuals who experienced painful bowel movements in childhood, sometimes tied to fear of using unfamiliar bathrooms, can carry that clenching reflex into adulthood without ever realizing it. People with anxiety or a habit of consistently ignoring the urge to go, whether due to work schedules or general routine, are especially prone to rectal hyposensitivity. Older adults are also more susceptible, since nerve sensitivity and muscle coordination naturally decline with age, compounding the effect. And people who have had prior pelvic surgery, childbirth-related pelvic floor trauma, or spinal cord involvement can experience disrupted signaling between the brain and the rectal muscles as well. Recognizing this pattern in yourself or someone you're caring for starts with paying attention to certain warning signs because they look different from ordinary constipation. One key clue is straining that produces little to no result, even when there's a clear sensation of fullness. Another is the feeling of incomplete emptying immediately after using the bathroom, as if something is still there, even right after a bowel movement. Unexplained leakage of liquid or soft stool, especially in someone who otherwise seems constipated, is another major red flag, since this is often mistaken for diarrhea when it's actually stool seeping around a blockage. Lower abdominal discomfort, bloating, or a sense of pressure that doesn't resolve with a bowel movement can also point toward this mechanism. And if increasing fiber intake actually makes symptoms worse instead of better, that's often one of the strongest indicators that the problem lies in muscle coordination rather than stool bulk. Adding more fiber to a system where the exit is essentially clenched shut just creates more volume, trying to pass through a door that isn't opening, which can increase bloating, discomfort, and even the sensation of blockage. So what actually helps when the root cause is this kind of muscular miscommunication rather than diet alone? The first step is recognizing that this is a retrainable pattern, not a permanent condition. Because the issue involves learned muscle behavior and nerve signaling. The solutions that tend to work focus on retraining that communication rather than simply adjusting food intake. One approach used by pelvic health specialists is called biofeedback therapy. This involves using sensors to give real-time visual or audio feedback about what the pelvic floor muscles are doing during an attempted bowel movement. Because most people have no conscious awareness of whether these muscles are contracting or relaxing, biofeedback essentially makes the invisible visible. Over repeated sessions, people learn to consciously relax the puborectalis and anal sphincter at the right moment, gradually replacing the clenching reflex with proper coordination. Studies on pelvic floor dyssynergia have shown that biofeedback training has meaningfully higher success rates than dietary changes alone for this specific type of case. Another important piece is restoring rectal sensitivity through consistent bathroom habits. This means responding to the urge to go as soon as it appears, rather than postponing it repeatedly. Over time, consistently honoring that signal helps the nerve endings in the rectal wall become more responsive again, rather than requiring larger and larger volumes before triggering the urge. Establishing a regular time each day to sit and attempt a bowel movement, even without an urgent signal, such as shortly after a meal when the gut is naturally more active, can also help rebuild a predictable rhythm. Posture during elimination matters more than most people realize as well. Sitting in a deeper squat position, achieved by using a small stool to elevate the feet while seated on the toilet, helps straighten the angle between the rectum and the anal canal. This can reduce the mechanical resistance that the puborectalis muscle creates, making it easier for stool to pass even if muscle coordination isn't perfect yet. For cases where impaction has already occurred and stool is currently stuck, this becomes a different situation that usually requires direct care rather than home management. Attempting to force a large hardened mass out through straining alone can cause tearing, hemorrhoids, or in more serious cases, injury to the rectal wall. This is when medical intervention, such as controlled removal or specific treatments to soften and break up the impacted stool, becomes necessary, and it should be handled by a healthcare provider rather than attempted independently. It's also worth understanding that this is not a rare or unusual problem. Studies on chronic constipation have found that a significant percentage of people who don't respond to standard fiber and hydration treatment actually have some form of pelvic floor dysfunction contributing to their symptoms. This means a large number of people have likely been told for years to simply eat better and drink more water without ever being evaluated for whether their muscles are working correctly during elimination. The frustration so many people feel doing everything right and still struggling often comes down to this exact gap in how the problem gets explained and treated. Understanding this mechanism changes the entire conversation. This isn't about willpower or discipline or even diet in most of these chronic cases. It's about whether the body's internal signaling and muscle coordination are working the way they're supposed to. Once that piece of the puzzle is in view, the pattern of stuck, hardened stool that never seems to fully resolve starts to make a lot more sense. And so does the reason standard advice so often falls short. There's also an important distinction between mild, occasional straining and a situation that needs urgent medical attention. Severe abdominal pain that comes on suddenly, persistent vomiting, an inability to pass any gas at all, or visible swelling of the abdomen can indicate a more serious blockage that goes beyond typical impaction. Fever combined with bowel symptoms is another signal that shouldn't be ignored, since it can point to a complication rather than simple constipation. These situations call for prompt evaluation rather than home remedies, because a fully obstructed bowel is a different and more urgent problem than stool sitting in the rectum. Age also changes how this condition tends to show up. In older adults, decreased mobility, weaker abdominal muscles, and a natural decline in the strength of intestinal contractions can combine with pelvic floor dysfunction to make impaction more frequent and more severe. In some elderly individuals, confusion, agitation, or a sudden change in behavior can actually be a sign of fecal impaction, since the discomfort and toxin buildup from a blocked bowel can affect mental state, especially in someone who cannot easily communicate what they're feeling. This is one of the more overlooked presentations, and caregivers are often the ones who catch it, simply because they notice a shift in mood or alertness before anyone identifies a digestive cause. In children, a similar cycle can develop, usually starting with one painful bowel movement that creates a lasting fear of using the bathroom. That fear leads to holding stool in, which stretches the rectum over time, and a stretched rectum gradually loses its normal sensitivity, creating a milder version of the same hyposensitivity seen in adults. Left unaddressed, this can turn into a repeating pattern that looks a lot like what's been described throughout this video, just beginning much earlier in life. Across every age group, the common thread is the same. Stool becoming physically stuck is rarely just about what's on the plate. It's about whether the signal from a full rectum reaches the brain clearly, and whether the muscles responsible for opening the passage actually cooperate when that signal arrives. Fiber and water still matter, and they're not being dismissed here, but they only address one part of a much larger system. When that system breaks down at the level of nerves and muscles instead of at the level of stool consistency, no amount of dietary adjustment will fully resolve the problem on its own. This is exactly why so many people feel like they've tried everything without success. They were solving for the wrong variable. The real fix, in a large number of these cases, isn't found in the kitchen. It's found in retraining a reflex that the body picked up somewhere along the way, often without anyone ever realizing it was happening in the first place. Once you see the digestive process as a coordinated conversation between the brain, the nerves in the rectal wall, and the muscles of the pelvic floor, the picture becomes much clearer. Every part of that conversation has to work correctly for a bowel movement to happen the way it's supposed to. When one part goes quiet or one part clenches instead of relaxing, the entire system can back up, no matter how much fiber or water enters the picture beforehand. Understanding where that breakdown actually happens is the difference between chasing symptoms for years and finally addressing the pattern underneath them.